I open the meeting of the Health and Human Services Oversight Committee for Friday, May 16th, 2025. And would the clerk please either call the roll or sound out names or whatever you need?
The clerk was trying very hard to get herself together and hasn't yet, but the clerk will now just write down who's here.
Attorney John Williams has volunteered to give some dad jokes in the interim.
He doesn't charge extra for those, does he?
Oh, I don't know. I just gave him some.
It's Representative Brown, isn't it?
Yes. And Representative Woods.
And we're all set.
We are good.
I thought I was going to figure out how to record an audio of this and turn it magically into minutes.
Would you like us to speak more slowly? Okay.
Complete fail on my part.
DHHS Commissioner's Update. And the chair recognizes Nathan White, Chief Financial Officer.
Good afternoon, Chairman, members of the committee. My name is Nathan White. I'm the Chief Financial Officer with the Department of Health and Human Services. The Commissioner was not able to be here today. I do know a number of you. I look forward to meeting others of you. It's a rarity that I get to come to this committee. Typically, I'm primarily over with Finance. It had been requested that the department provide an overview of lapse information and a personnel update. My understanding was the intent and sort of the long run was to start to look at this on a regular basis. What I have before you today, there's a document that says DHHS Oversight, Budget and Vacancy Rate. And I prepared a 2-page document that I will go through now. And there's a couple of key takeaways here. One is, as we're headed into a difficult biennium with budget, I think lapse is certainly, it's been a question on the current Senate Finance. I know it was certainly a question on House Finance's mind. I think it'll be a very important, critical piece of the budget as we move forward. And so I was asked specifically to talk about that and also just provide a brief update on the department's vacancy information right now relative to its personnel. So there's a couple of key elements that I just want to talk about before we go too far into this. And our department, our budget is large. It's a little less than about 50% of the entire state's budget. And there's a couple of key things concepts that I want to talk about. The first is a back of the budget reduction. And so the budget is passed. And in the back of the budget on page 787 or so very, very far back in the back, there is a provision that says, we have given you $1 billion of general funds. However, now you need to reduce your budget by 23 million is the current back of the budget reduction. And so what that does is it requires that the commissioner effectively reduce expenditures at her discretion in the biennium by the required amount. There's also a concept of lapse that I think many of you are familiar with, and sometimes the back of the budget and the lapse gets muddled together. The lapse is the assumption that the legislature uses, as well as the governor when she introduced her budget, to effectively assume that I'm going to appropriate you $100 million. I'm going to assume you're going to spend 98% of that, and the remaining 2% will lapse back to the budget. So that's not technically in the law. It's not technically in the budget, but it's an assumption that's used as part of the LBA's surplus statement, which is basically shows your expenditures, revenues, and then your lapse to balance the budget. And the lapse, it's received less attention in the past couple of years where we've had a very strong economy. We've had a lot of really strong revenues. It's received less attention than it had in the past, probably 10 years ago, where oftentimes agencies were being asked for updates on lapse on a regular basis. And there was a recent change in law whereby state agencies are now providing a regular update to the legislature relative to the lapse. And HHS's lapse, I think what's important to understand there is while we do represent about half the budget, we only have so much control over the expenditures. And part of our budget and part of our lapse, the money that we're not going to spend, is driven by the utilization or the need in the community. So this could be the Choices for Independence program, I think is a good example, where there may be a need, but then you also need to have a labor market available, and then those Choices for Independent Medicaid payments would only occur, A, if the need is there, and B, if the expense is incurred. The child care scholarship is another good example of this. Is there a need? Are people applying? If those two factors are there, then that expense would occur. Foster care, another good example. There may be a need. Is there a family that's willing to step up to do that? And those are the kind of factors that drive part of our lapse. Another major piece of our lapse is also driven by our contract spending. So HHS has about $1.5 billion in state fiscal years 26 and 27 in contracts. However, once you back out the managed care organization contracts, that's well over $1 billion. We end up having about 400 million remaining in contracts. And so we enter into a contract, but we only pay for the costs that are incurred, or we only pay for deliverables. There's been a general operating principle by the Executive Council that approves all of our contracts that does not allow us to make advance payments. So while we may budget $1 million for a contract, we will only pay for the services that we receive. And so any money at the end of the year that's not spent in that contract would then go ahead and lapse. And I think that's that's one of the tricky elements as far as predicting lapse, because you have to make a number of assumptions about behavior, need, capacity, the labor market, and other variables. And traditionally, I think a lot of people often think about state agencies and their personnel being a big cost driver. What's really interesting about HHS, and this is something I really like to remind folks, is our personnel is about 10% of our entire budget. And of that 10%, about 54% of that is actually general funds. And general funds, that's the money that we're going to be lapsing. So it's actually a relatively small piece of our budget. I think it's different from other state agencies like state police or Department of Corrections that is really personnel heavy. While we do have a little over 3,200 full-time authorized personnel, from a dollar perspective, it's actually about 10%. And I just always like to highlight that. If you move down to the bar chart there on the first page, so there's another peculiarity around our budget. And in the first year of the biennium, you'll see the 735 number and the 366 number, and that's the total funds from the governor's recommended budget for 26 and 27 there. But what you'll see in the first year, a vast majority of our general fund appropriations cannot lapse, because there are state laws surrounding that, or there's footnotes. And what you'll see in the second year is you'll actually kind of see that inverse quite a bit, where you'll see that more money becomes available to lapse, and then any of that money that we did not spend in the first year that carried forward, some of that could lapse in the second year. So what you'll normally see is a relatively small lapse from our department in the first year, and a significantly higher lapse in the second year. And that's driven partly because the Medicaid budget under law for the past couple of biennia has not lapsed. It's actually carried forward as part of that program. The developmental disabilities accounts, there's 3 of them. Those have special provisions in state law to ensure that that money carries forward and it's always spent on DD services. And so we've carried a balance forward from year to year. And that's about $1 billion of total funds. It's $500 million of general funds, 50-50 match. And then there's a couple of other areas and certain class notes and org notes as well that kind of feed into this. But I just want to be folks to be aware of that, because when you do look at the surplus statement, you will see in some years you will see a higher assumption that there'll be more money lapsing out of that second year. And this is part of the reason why that's important just to recognize. If you turn to page 2, What I've tried to do here is I've put together a table, and this has the final operating budget for 24 and 25, and it has the governor's recommended budget as introduced for 26 and 27, and then the House budget as passed for 26 and 27 there as well. And what's really interesting about the current biennium is a lot of the actual operating costs were included in HB1. So that first row there, that's House Bill 1, that represents your operating budget. But we actually had a lot of operating costs included in House Bill 2. I think like the Medicaid rates is a really good example. There's $134 million of general funds alone in House Bill 2 for Medicaid rates that, you know, arguably are operating costs. And the Senate recently, obviously it's not finalized, during the House phase there was that provision to reduce Medicaid rates by 3%. The Senate recently struck that. You know, we'll still wait and see, and we'll go through the process to see where that lands. And then in the third row there, there are also other additional general fund legislative appropriations from 24. There's about about $7.7 million there. And then below that, you will see that back of the budget reduction. So in state fiscal year 24, 2025, you know, a little over $23 million, not that bad. For the next biennium, though, currently we are looking at about a $23 million back of the budget reduction, general fund in each year. And that, yeah.
I beg your pardon. Could I just stop you so I get this down correctly?
Yeah.
Are you now talking about the budget that we are in currently, or the budget that that is being proposed for the next?
Sure, I'm actually straddling both. So
Okay. If you could make it clear when you are, because if I may, Mr. Chairman, my understanding of Senator Gray's concerns were what is happening with this current fiscal year and where are we with this current fiscal year.
Yep.
And so getting into the next fiscal year seems to be a leap, but
Sure.
you just go where you need to go and
Sure.
that'll be
Well,
fine.
if I go ahead, so if you look at state fiscal year 25, and you go right down to the bottom, and you'll see the estimated by DHHS that is our general fund expenditure lapse. So you'll see currently we are estimating approximately a $60 million general fund lapse for state fiscal year 25. And last year it was about 13.5 million. And so that corresponds with some of the information presented on the first page, just trying to explain why that second year figure is higher. Again, it's because a lot of that money by law carries forward. And part of the reason that I was talking about the back of the budget cut that we anticipate going into the next year is that's going to impact operations because we'll have to make a reduction. We've also seen about a $30 million general fund reduction to our personnel, and then we lose, 50% of the federal funds matching there. So it's about 400 positions just shy. And I think that's just kind of important to recognize. Well, we do see $60 million of lapse this year. When I'm looking at the surplus statements for the 26-27 biennium, they're assuming 2% and they're assuming a 3% surplus lapse across the state. And so I provided those numbers just at the bottom just to kind of provide some context so that, well, this year's the 60 million. In the future, we are looking at that, and I was providing that just to help kind of inform how the Senate would want to balance that. And I know Senator Gray was very interested in that, but I know he wasn't able to make it here today. So I can kind of pause there before moving to personnel. I don't know if there's any questions related to any of that.
Yeah, I have a question going through my mind is a terrible thing on 60 Minutes where it was talking about federal departments, bureaus, whatever, who, God forbid, they should ever let their budget have a lapse in it. So when they saw one coming, they'd go out and buy furniture and store it in warehouses, furniture they'd never need in warehouses that are expensive to store it in, simply so they wouldn't have to give the money back. I think what I'm hearing here is we don't do that.
We do not. I do think that you can see that across various governments. I mean, you've seen it make the headlines and things like that, where people make a bunch of purchases at the last minute. That is not a practice that we engage in. The one caveat to that is that we do have a facilities budget, and our facilities budget, it carries forward from year to year, and we always try to strike a balance between recognizing a need. So when we go into a budget, we recognize a need, but we sometimes hold on that purchase because we want to make sure there's not a flood or a fire or a pipe burst or whatever it might be, so that we have funding available for that purpose. But the general practice of making a bunch of last minute equipment purchases, that is not something that we engage in.
Thank you.
course.
A second question is, I hear, not for a public attribution, but the phrase, we can probably find money for that. And when something lapses, it lapses out of a line item down to where lapse money goes. It cannot be kind of slid around for worthy causes that a while ago we didn't think we had the money, but guess what? Now we do.
Sure.
There was a question in that statement there somewhere.
I will do my best. So there are mechanisms to transfer funds. And on July 1, 2025, hopefully we will have a budget, and that will be the budget that we will use as our base. And within the existing laws, I think it's RSA 916A, we have the authority to transfer within an account and class lines, certain class lines. There are specific restrictions for utilities, transfers to DAS, and other class lines up to $100,000. Now, without fiscal committee approval. But once we exceed that amount, that's where we need to go back through the legislature and request authority to transfer funds. And so today on the fiscal committee agenda, we had our department-wide transfer. And we do this about 3 times a year, where we submit a department-wide transfer, and it's followed by a large Excel sheet. And we show each class line and each dollar, and where it's coming from and where it's going to, and the reason for that transfer. And we do that because we sometimes have specific needs that arise. So I think a good example is the SYSC budget. We had a situation where we had overtime over and above the budget. We had personnel costs over and above the budget, where we had to move funds into that area in order to make sure that we could meet that need. Another example from today's fiscal committee item was we need to make sure that we had sufficient funding for the Medicaid payments for private nursing facilities and the county nursing facilities. So we moved millions of dollars over to make sure, from areas where they would not be spent, to make sure that we were meeting those legally obligated needs. So that's and then it also goes through the governor and executive council for additional scrutiny. So there are processes in place, but it's a very transparent and public process anytime we have to move money over the threshold established by statute.
Let's give you a hypothetical that there is a hypothetical chairman who has a wonderful hypothetical bill that would hypothetically do phenomenal things, but there is not the money for it in the current budget. But boy, DHHS and the Executive Council and the governor all think this is a fantastic thing to at least get it going. Money could be found?
So there was a conversation at fiscal committee, at the prior fiscal committee, where one of the members had raised concerns relative to moving money for last minute purchases, so to speak. And so again, I think generally because of the sensitivity around the lapse, because they didn't want to have money be moved to be spent on new things at the end of the year, because those funds would lapse, and currently the state is looking at dipping into the rainy day fund And so I've had conversations both publicly and privately where certain members within the finance committees have had concerns about taking money away for new projects that would otherwise go to the laps to support the budget, that would have sort of those downstream effects as pulling from the rainy day fund. So there, to directly answer your question, those types of things are possible, but they require, again, that public approval process with a number of different parties.
Under $100,000.
Well, the $100,000 is cumulative for that specific account. Anything above that would require the fiscal committee process.
Thank you, Representative Weber.
And to continue the hypothetical, I heard the hypothetical being a committee chair having a great idea. Am I assuming that the committee chair actually had that authorized by the legislature? Or is the committee chair just digging around for a new project? Because I wanted to make that clear.
It would be the former.
Yes, okay, got it. So authorized very late in the legislative session for that fiscal year is what you're talking about. Okay, great, thank you.
Any further questions for Mr. White before he continues his presentation?
Okay. And then on the bottom of page 2, I have provided, this is a, just a quick unclassified, this is the full-time, permanent, and unclassified positions. So this represents our classified and our unclassified positions. This is roughly a little over 3,200 positions that are currently authorized in the budget. And this shows the vacancy rate over the past several months, or over the past 12 months. Currently, we're at about a 14.5% mark, and there was a hiring freeze that was put into place back just a couple of months ago, where we saw a little spike and an increase once we were trying to get a handle on what that meant. And it did exempt direct care positions, so we are still able to hire for direct care positions. But there is also a waiver process for non-direct care positions that the department works through the Division of Personnel and the governor's office on. And so, you know, overall, we have seen a slight uptick to where we are now. Part of that, too, though, is because we, as I mentioned earlier, as a department, because we are anticipating that $30 million of general fund reduction to our personnel, which again equates to a little less than 400 of our positions. We are planning for that so that when we hit July 1, we are not overstaffed in excess of our budget. We have a central team at the department that reviews all postings of all positions right now to manage that effectively so that when we hit July 1, we will be within our budget. And there's obviously a balance there, but effectively 12% of our positions have been unfunded for the 26-27 biennium, and that's something that we manage internally on a weekly basis. So I can pause there. Any more questions?
Representative McDonald.
Thank you, Mr. Chairman. Commissioner Weaver did a great job in a previous appearance before the committee talking about the impact of the $80 million that got canceled by the federal government. As the department, that's not directly perhaps related here, but I'm just curious about how the department is continuing to adjust to that.
Sure. So the positions, the DHHS positions that were directly impacted by that, we worked internally to find vacant positions to ensure that none of those individuals were laid off. So there's been no direct impact there. We had planned for an exit, so to speak, from those funds. Only we had planned for a year and a half, not a day. So there is no direct impact to the budget numbers because these were all the ARPA funds that were intentionally not included by direction when we put together the budget. So are you looking for more detail on what specific? I apologize.
Just trying to assess the impact. I know it was a very sudden thing to have occur and a considerable amount of money. Just wondering about the personnel impact and the program impact, if you can share those.
Great. So thank you, Chair, if I may. Hello, I'm Patricia Tilley. I'm an associate commissioner at the department, and those the 80 million in funds really happened within two divisions of DHHS, in our division for behavioral health services and the division of public health services. So as Nathan described, we were on a pathway anyway to sort of wrap up those funds. So some of the impacts impacted our communities because many of those dollars were in contracts, which we essentially ended that day. So there are community impacts to that, and our community agencies have had to make decisions around personnel. In particular, we had a number of community health workers out in the community. And so whether they were our regional public health networks, our federally qualified health centers, our family resource centers, they've had to make decisions because we've said the funding is no longer available. So it was felt acutely in those communities. For the department itself, as Nathan noted, we had roughly 20 positions. Most of those positions we could move around a little bit. They were all in the Division of Public Health Services. A number of them were highly technical laboratory positions. And so we were able to shift with other vacancies to say, you used to be doing this work for wastewater, for example. Now you're going to do something for food inspection or in doing there. So we were able to move skill sets around for the most part. A handful of folks decided to leave state service, so they were getting closer to retirement. So they sort of opted out in their own way and said, this is the writing on the wall for me. We will take that opportunity. And then a handful of them, a very small number, about 3 or 4, we actually moved into other areas of the department where there were needs. So for the most part, everyone was kept whole, or certainly voluntarily kept whole. For the folks that left the department, they did that on their own voluntary terms. The other folks, we found a fit. One of the things that's a long-term consequence of that, though, is if we have additional federal funding and terminations, we sort of used up all our space. So we were able to do this. We had 20 people. We did an incredible amount of work shifting everyone around. Right now, we've sort of taken up all the wiggle room. And so if we have another ending of a federal grant, we will have less flexibility in the future. We will work with them at the time. We're a people-centric organization. We're always going to go people first. We want to make sure that we keep people whole. We value their service. But it has made it more complicated, sort of looking forward, knowing as we all read the tea leaves of what's happening at the federal level, we know that this isn't the end of cuts in the future. And the tricky part is we don't know exactly where those cuts will be. We've all seen sort of ideas, but at the end of the day, it'll be some time before we know that those land. So that's the personnel. From the some of the internal stuff, the other place that really took a hit for us was some of our IT projects. And again, and those are things that, really are not visible to the outward world. It's things like how we have our immunization registry and making sure that we're doing fine-tuned fixes to some of those data systems. And we were able to find some other federal resources to fill those gaps to make sure that those things could continue. But definitely we've had to be very strategic about what we continue to do and what we stop doing.
As you know, there's always a new bill before the Health and Human Services and Elderly Affairs Committee about the department tracking data for this, tracking data for that, measuring this, measuring that. So when you say that some of your IT projects took a hit, that would affect your ability to meet those
100%
desired objectives.
Yes, sir. I mean, I think that that's one of the things we're being very careful about right now. Everyone wants data, and quite frankly, we've been able to provide great data in the department especially over the past 5 or 6 years, and the funds from the pandemic were helpful. We got a bolus of funds in there to really modernize our data systems, but this 80% or $80 million reduction showed our vulnerability of some of our reliance on those federal funds. So we will always have to think carefully whenever someone says, I've got a great idea. I want to measure these 10 things in this way and have it on a dashboard. All of that, as Nathan reminds me every day, costs money.
Let me follow up on that issue. In children and family law, there is sitting a retained bill asking for data from DCYF. this would be something where perhaps that bill might now be considered aspirational only and not likely.
So I think that's great. So again, the 80 million cut didn't impact DCYF directly. I just want to be abundantly clear. But the notion that data costs money is absolutely true. We were very fortunate. We recently passed through the Governor and Council some funding, a significant amount of funding that had a match of both federal and general funds to build out a modern data system, a case management system for DCYF. It'll be called Granite Families. The system we're using right now was built in 1997. So if you can, it looks like the way AOL sounded. Like it looks like there should be a modem in the background making noises. And that's what some of our most important work in the department was dependent on a system that was clearly outdated. So we're thrilled that we have the opportunity now to build a new system. But to your point, in order to reap the benefit for that, we need to make sure, we will need to continue to bolster that to be able to have the kind of dashboards and Tableau settings and things that we all expect right now that you should be able to Google and just pull up. But that takes both time and money. And our priority in DCYF right now is simply to migrate to a new system that is, 21st century.
Thank you. Any further questions?
That is all I had. Thank you for your time. Appreciate it.
Thank you, Mr. White. I've been involved with DHHS in one capacity or another for 9 years. I think this is the first time I met you.
I believe so. They don't let me out of the office much. I go down to Senate Finance, so that's where I spend a lot of my time.
We're much friendlier. Thank you.
I'll be
for
sure to
coming.
come back.
Thank you for coming. I'm reminded that I skipped over the minutes, and Representative Dry is here as an alternate, not with the official paperwork we usually get for an appointment, but from a nod from the Speaker's office. Would Representative Woods be somehow seeable as an alternate member? Otherwise, we don't have a quorum. Okay, and who is Representative Woods to us then? Are you a full member? Oh, I guess I didn't look at the memo. Yeah.
But my answer would be, I certainly assume that she would be available. So is Representative Dry still in process?
She was, I was given a nod as, sure, why not? Which I will interpret it as okay.
Because I have put her in the minutes as being here, and I put her in as qualified last time.
She's very
This
qualified.
time,
Same thing.
we're still under the same thing.
The official notice has not come.
I'm not gonna even have heard that.
Well, then I think we have a quorum. And let's take a look at the minutes from
And
last time.
Representative LaMontagne will be voting. Is that correct?
She's fine. So do we have the minutes from last meeting before us? We do?
Yes.
Well, okay. Any questions on the minutes from the last meeting? Any corrections, emendations? Typos? Okay, turn your mic on and show a typo.
Just simple stuff like page 6,
Page 6.
line 6.
Line 6.
Last time looking at patients,
1,
plural.
2, 3, 4, 5. Okay, that should be plural.
It was just the first word, patient, should be patients.
I'm sorry, I still didn't hear it. You have to-
Plural, should be plural.
How far down on the page? I just-
Line 6.
Line 6.
Yep.
First word. And then 3 up from the bottom, where it says Rep. Pearson asked where they are. Yeah.
I do
should-
speak that way sometimes.
she probably read it verbatim. Yeah.
Where they were from.
Yes.
Okay. Anything else?
And I would just request if people see typos, if they could possibly just email me beforehand, then I can correct them and Mr. Williams can print out a corrected version, and that would be helpful.
Seeing nothing else, Chair will entertain a motion to accept the minutes from the last meeting. So moved. Second. All in favor?
Aye.
Thank you. Approved. And while we're doing a little bit of housekeeping, how many of you, this is just thumbs one way or the other, would like to meet on the fourth Friday of June as opposed to not? And I've been told that while everything that could happen in the next meeting is certainly worthy of hearing, nothing is urgent and it could be deferred to the September meeting. So how many of you really want to come here, or actually probably over in the State House? I'm holding out for Tandy's. They said that's not possible. But somewhere in the State House next month. How many of you would like that? Thumbs up. How many of you would be happy to defer to September? Completely ambivalent. Yeah.
Mr. Chair?
Yes and no. Wishy-washi's, I got that. I know the distinction. Representative Woods.
Yes, with the caveat, I would sort of move for the September. But by the same token, as we found out last time we had a report about the $80 million that got scooped up, there might be some other similar item that might require our attention that we could meet, but tentative, put it on the calendar that we won't meet unless you decide or someone precipitates a discussion requiring a meeting.
Why don't we give it a definite maybe and watch what transpires in the next 2 or 3 weeks, and then we can poll this?
Yeah, that's what I'm saying.
Okay, good. Thank you. Thank you so much. Next up, internal audits conducted by the department's Division of Program Quality and Integrity. I do favor those with integrity. Thank you.
So do we. Good afternoon, Mr. Chair, members of the committee. It's good to be here. My name is Meredith Tellus. I'm the director of the department's Division of Program Quality and Integrity, and I'm joined by Teresa Narrow, our internal auditor for the department. And we're going to be talking about internal audit, and you should have a black and white PowerPoint deck in front of you that says internal audit on the front of it. I apologize, I did not page number this. I will do so in the future, but it does have dividers in it that I'll be able to refer to, and so we should be able to stay on the same page. So the second slide here is simply an agenda to let you know what we're gonna talk about. This is sort of an overview introduction, so just giving you a little bit of background on the work functions of internal audit, the organization, what it looks like, what we did for 2025, what we're planning on doing for 2026, and then we have a brief graphic just to try to show you what some of our work looks like. So the next slide is one of those dividers. Internal audit background is what it says. And if you go to the slide after that, it's got a list of our typical functions. So there are a number of functions that can come up in a day for Teresa and her staff member. But our typical functions are fraud and unethical conduct reviews, quality assurance reviews, LBA audit facilitation and follow-up, and independent third-party reviews. So fraudulent and unethical conduct is where we get a referral from anyone in the department who has any kind of concern about fraudulent or unethical conduct from anybody else in the department. They can send an email and say, I've got some kind of concern. Sometimes they might go to the ombudsman. We work very closely with the ombudsman, and we determine between us and the ombudsman where a referral is more appropriate. Teresa and her staff will look at it, do kind of a deep dive, and then decide whether or not it's something that needs to be pursued from a personnel perspective, whether or not there was something that would be very unfortunate that we needed to discuss with law enforcement or our attorneys. And they would do that work and then produce some kind of report on that.
Let me stop here and ask a couple questions just about fraud and unethical conduct.
Yeah.
I chair the Committee on Reform of Family Court, so believe me, I get a lot of questions about all of these horrible state employees who act very badly. So it is something that rings in my mind. you're saying anyone in the department could bring forth. How about the public?
So the public will go to our ombudsman.
Public to the ombudsman.
That's
This is
right.
good to know.
Yes.
So in other words, they don't email me.
Right. You
Thank you.
you
I
can
appreciate-
refer them to the department's ombudsman.
All right,
That would be
good.
appropriate.
Uh,
Yep.
Secondly, you said somebody in the department could email you about this or email you through the ombudsman. How public are these emails? How much can they be discovered?
So I'm not sure I can answer that. I don't know that there's anything precluding the fraudulent and unethical referrals from being public. I will tell you, this is very fortunate. We don't get a lot of them.
No, I didn't think so.
And I'm glad that we don't, because we don't want to think that there is a lot of fraudulent and unethical conduct. Sometimes when we do, it is something where someone has left and a supervisor is looking at their work and they're saying, I'm not making heads or tails of whether or not this was appropriate. And then they contact us so we can go in and do a review to say, was there anything happening here that we would be concerned about? I will tell you, most often what we find is not fraud, and this is a good thing. It's not unethical conduct, and this is a good thing. It is what I'll put in the category of maybe poor judgment, lack of training, things that we can work around and fix in the future. We can say we've got some internal controls we want to beef up and fix here, but it's not a common occurrence.
Do you have a whistleblower policy?
The state does,
The
yes.
state does. Okay, good. Anything else on this issue? Representative McDonald.
Yeah, just to clarify, when you say fraud, that's not program integrity type stuff.
Right, what you're thinking of. Yeah, exactly. So, it's fraud in the broad sense of something that happens with intent
But
generally
among
for
among
someone's
employees
personal-
of the department, you mean, or?
for employees of the department. Exactly, yes.
Thank
Yep.
you.
Okay, good. Thank you. Please continue.
Certainly. So quality assurance, so the second one on here, quality assurance and independent third-party reviews are actually very similar, where quality assurance reviews happen within the confines of our quality assurance statute and our quality assurance program. But they're similar in that it's any time that management determines that they need to understand something better and they don't have the 2 or 3 months to stop doing their day job and need to call in someone else to be able to do kind of what's listed here, interviewing staff, reviewing policies and procedures, reviewing backup documentation, maybe doing site visits, taking samples of any kind of databases to do really a thorough investigation and then be able to report back what we're seeing. It is a benefit to management sometimes to have that done by a third party who's unbiased and doesn't really care what the outcome is. So we're able to have those conversations and let them know what we see. And then the last function on here, the LBA audit facilitation and follow-up, is an ongoing function that Teresa has been engaged in for many years, which is to bring us into compliance with Executive Order 2014-03, which requires us to follow up on all LBA audits and actually post our work on Transparent New Hampshire. So that's the last function there. And the next slide here for internal audit, organization and 2025 reviews. Yes. So we only have 2 people in the internal audit function, and it's Teresa and her staff member. It was created in 2018, but we didn't really get started on a lot of actual reviews until the last couple of years, because a lot of what Teresa was doing was kind of more basic foundational work, like just setting up policies and procedure templates, guidelines on how we expect people to use them. Getting into compliance a little bit with Transparent New Hampshire from old audits and reviews. So that was a lot of the work. And then we've started on a number of reviews more recently. So you'll see that under 2025 in this fiscal year, in the first, 9 months of this fiscal year, we did 1 fraudulent and unethical conduct review, 1 quality assurance review, and 1 third-party review. That's what's been done so far year to date. And the next slide is a divider saying for 2026, potential reviews and tasks. So one of the next important tasks is going to be developing a training for those policies and procedures and how we expect people to use them. Teresa has done a lot of training, but most of it's been live. And now we're going to use our learning management system to be able to set up training that people can take ongoing. New employees can always go there and take. Existing employees can use it as a reference for how they're expected to develop policies and procedures and how they're supposed to use the templates that we have in place. Future potential review areas. We get a single audit of our federal funds every year, and that's conducted by KPMG, hired by the LBA. Those reviews are, some of our programs get reviewed every single year. Other programs are on a schedule. They only get reviewed every 3 or 4 years. Some programs it's ad hoc. But the test for that audit is available in June or July of every year. It's called the compliance supplement. So one of the things that has come up is 4 areas that maybe only get reviewed every 3 or 4 years, or it's more, they're big programs, but it's ad hoc. Why don't we go in and try to do the test in advance of when the auditors come, so that we know that we're in compliance, we know where our risk areas are. So that's one potential area. We've developed a new data retention procedure for hard copy documentation among the departments. So one area we could do is review the implementation of that, how well people understand it, how well they're implementing it. Ad hoc program area reviews, anytime, again, managers would like us to look more closely at their training, at their contracts, at the way that they do quality control among their own programs. We would be there and help them with that. And another specific area is the invoice review process, sort of just looking at how program areas and finance areas work together for invoice review and the pain points there. So any questions on that before I move on? Okay. The next area is outstanding LBA audit observations. Again, was just to try to provide you a visual of some of the work that has been done. And the graph here, what you see is from when we started in 2020 to today, observations that we have had outstanding or have received in a year from an LBA audit, whether it was financial audit or a programmatic audit, is the darker bar on the left. That's the total number of findings. And then the bar on the right, that's a lighter color, is the remaining findings at the end of that year. So the gap between them is the number of findings that Teresa worked with any program area to understand what they've done to remediate the finding and come into compliance. And so then on our Transparent New Hampshire report, we can say that this has been partly resolved or fully resolved, and we keep working on it the following year. And then when it's finally fully resolved, it would not show up on these charts anymore.
Representative Dry.
Thank you. So this kind of correlates to a little bit after you started doing all your policy things. Are you claiming credit for this? It's a great sign.
Yeah, that's what we thought would be an excellent representation to show you folks here today, is because you can see when the position, I mean, that's just the last 5 years. I began 7 years ago, but you can see once I started how it's all been brought down for our findings. So we just thought it would be a great visual to bring today, so you could actually see it. Like, it's one thing to talk about it, or for you to actually see it graphed out.
Is that good? Follow up?
Follow up.
And if you do the testing for the policies that are intermittent, would you think that maybe your dark line will start to go down as well?
This representation is only for LBA audits.
Okay.
We would hope that would come down for our single audits. So it's a different audit. So those findings where we're talking about doing those testings in advance aren't represented here. This when we say LBA audits, it doesn't include the KPMG audit. I apologize.
Oh, that's not.
Just want to make that clarification. Yeah.
Okay, thank you.
And that is everything that we had for you this afternoon. Any other questions?
Any questions before we say thank you? Thank you.
Thank you very much for having us.
Advisory Council on Child Care Annual Report. Marianne Barter. That's hard for me growing up where I did. I want to say Barter.
Everybody does.
Oh, good. Thank you.
Hi, I'm Marianne Barter. I'm the chair of the New Hampshire Child Care Advisory Council. Thank you so much for having me here today. So we prepared a report about the Child Care Advisory Council. The first few pages are really just talking about what we do and the lens we use. So the purpose of the Child Care Advisory Council is to inform state leadership or the field if there's anything that's going to get in the way of expanding safe, affordable childcare statewide. So anything that might impede childcare statewide, that's what we're interested in. And we're looking at it through two different lenses. So we're looking at it from the importance childcare has to the family and how important it is for the child to make sure children are in safe spaces with adequate staffing and regulations that keep people safe but aren't excessive. And then we're also looking at it through the financial lens. Childcare is an economic driver. And when childcare is not readily available, we know our business community cannot meet their needs, their staffing needs, and that we also know that they can't prosper and grow without the support. We consider ourselves the workforce behind the workforce. So specific actions that we've had this year, if you look to page 11, these have been our focus areas this year. Child care liability insurance. Currently, there are only 5 insurance companies that will insure child care programs in the country. And yeah, it's an incredible problem. And childcare costs for liability insurances are really going through the roof. We met with the insurance department. They're terrific partners, and they have put out a survey to see what other companies might be interested in insuring childcare providers. And they've put together a training that should happen next week about how we can lower our risk and how we can be more attractive to insurance companies. So we're looking forward to that. We're very interested in recruitment and retention of the workforce. So currently, childcare providers, the average wage for a childcare provider is $15.62 an hour. The only people who make less are you guys. So it is a very challenging field for something that's hugely important to both the state economy and to children and families. So we're looking at ways to improve recruitment and retention into the field. We support family child care. A few years ago, a bunch of federal regulations came down that really decimated family child care in the state of New Hampshire. And we've been working hard to build those up again. So family child care is an important part of our ecosystem in New Hampshire. And there are towns where a center-based program couldn't possibly be sustained. You know, we have some very small towns in our state, but a family child care can meet the needs of the community really appropriately. So how do we support them and how do we help them grow? Streamlining licensing rules. We've just finished a multi-year process of going through the child care licensing rules line by line in conjunction with the Child Care Licensing Bureau. It was the Child Care Advisory Council Executive Committee, 11 child care providers chosen from all over the state from different types of child care programs, and the State Licensing Bureau worked together on this process. And it's ready to go to JELCAR, and we're expecting it to be heard in August. So that's very exciting. Oversight of state contracting. So we have to make sure that child care programs are supported with any state contracting that happens, and that and we've worked closely with executive counselors to make sure our voice is heard if we are concerned about something or if we worry that something's going to hurt the field. We have some tremendous partners on the executive council, including Janet Stevens and John Stephen. They've both been amazing. Enhancing granted steps for quality. That's a quality initiative that's required. The federal government requires that all states have a quality metric for their child care programs. In New Hampshire, it's voluntary, and participation has been very low. We've been working with our partners at DHHS Child Development Bureau to try to make this a more manageable program for child care providers, because there are some funds attached to that. And if child care programs can meet quality metrics and access these funds, that's good for everybody. The impact of environmental regulations. Recently, the lead regulations in New Hampshire have become very strict, which is great for child safety. However, it does add an additional financial burden to child care providers. So we recently found out about a program that had to do over $100,000 in lead remediation at their facility because one child had tested high for lead. Now, we don't want any children to test high for lead, and we want all of our programs to be safe, but we want to make sure that we come up with some funding sources to help programs if this ever happens again, because $100,000 for a child care program can sink it. The margins in child care are very, very low. And then ensuring that data and information is communicated to the field. So we always think of ourselves as a little bit of a go-between between the field and the state, and people reach out to us every day when they just want to know things. So we want to make sure that we keep those lines of communication open. Any questions? we've been busy.
Any questions?
And looking ahead, so, to remain responsive, childcare is still in crisis in New Hampshire. We don't have enough of it, and not enough people are going into it. So how can we help support the field and help it grow, and in which case will also help the state of New Hampshire grow? So we want to increase visibility and communication with stakeholders across the state. So reaching out to executive counselors, reaching out to the insurance department, that's sort of new for us, but it's been incredible partnerships. So we're so glad that childcare is not as siloed as it used to be. Drive systemic change to ensure childcare is accessible, equitable, and economically viable. There's no point in having a glut of childcare programs in the state that parents cannot afford to send their children to, right? So anything we have to do has got to go through the lens of how can we make this as affordable as possible for families so they can support this, so children can come and families can and parents can work. We want to support DHHS in their search to fill the bureau chief position. They've been without a bureau chief for the Child Development Bureau and Head Start collaboration for several months now. And that's a really important role. That person really is the person who speaks to childcare providers. That is the person that brings forward anything that's happening on the state level, regulatory changes, anything. They're the ear to the ground for the childcare field. So we're looking forward to supporting DHHS as they search for the right person. We're reevaluating our council membership. So recently we've embarked on a much closer relationship with the business community. And we want to make sure that the business community has a strong voice in our council because they are affected economically by the work that we do. We're looking at alternate revenue streams to fund childcare in New Hampshire. And we're creating a centralized resource hub for childcare information. So in the future, we really see ourselves as a clearinghouse, a place where we have the information and we make sure that it's available to anyone who is interested. And that's what we've been up to.
I've got a question.
Of course.
I think it should be obvious that on the one hand, if you make regulations to protect precious children very, very, very large, you have protected the children and put the place out of business. On the other hand, if you lower them so that it is easier and less expensive to provide such facilities, you'll have more facilities, but children will get hurt.
Absolutely.
So it must be you live in that intersection. And I think I heard you say that a few years ago, the feds came down with, would it be much more strict regulations?
Yeah, they really did. There seemed to be right around, I don't know, the early 2010s, 2012, right after the recession, there were some really strong ideas about what childcare should look like. And there was a strong preference federally towards center-based childcare. But when you live in a state like New Hampshire, that does not work. We have communities that are very, very small here. And the North Country, which is really vibrant and an exciting place to be, but we can't expect a small town in the North Country to sustain a 60-child childcare center. That's just not appropriate. So family childcare fills that niche. So we're really trying to support family childcare programs as they open. And we actually received funding from the CDFA to work with a partner to create a opening up your family childcare guide, which was really well received and is kind of a living document where someone who's interested in the field could look at that and say, okay, now I kind of understand the way this works.
Are there collaborations between other small states, like New Hampshire? Nebraska has a lot of rural places, North Dakota is almost all rural places, and so on, to face the same issue? And a follow-up to that would be, has that group, assuming it talks to each other, come up with alternative suggestions to the federal stringent rules?
Yeah, the federal stringent rules have settled down. So things have become a lot more manageable for family childcare. New Hampshire's very unique perspective is that we have pretty strict zoning laws. So we've been looking at that. We've been looking at communities that where it's easier to open up, I don't know, a bumper sticker shop than it is to open up a childcare facility. So it's really important that we look at all the things that are kind of death by 1,000 paper cuts, right? So we're looking at all the things that kind of get in the way of doing that. And going back to your childcare regulations question, we do live in that crux. And that's part of the reason why that committee was put together to look at the childcare licensing regulations. We had over 100 pages of regulations. So I think it was 118 pages. The only thing longer than our regulations was Moby Dick. But with this committee, we were able to cut 1/3 of that out. And that's pretty dramatic. When you're getting down to a document that's about 60 or 70 pages, that's something, and not all of it's going to be relevant to your program, right? It's going to be different, different types of programs. You're getting to a point where the regulations are a lot more sensible and a lot more easy to remember. It's a lot less to process for providers. But we do talk to other states constantly. Maine has been a very close partner for us.
Representative LaMontagne.
Hi, thank you. Can you
You're
tell
welcome.
me what?
Thank you, Mr. Chairman.
Thank you, Mr.
Yeah,
Chair,
then-
and thank you for taking
yeah,
my
got it.
question. What percentage of children in child care in New Hampshire are enrolled in Head Start programs in New Hampshire?
I'm not sure. I would have to defer to Chris Santinello for that.
Okay.
Of course. Sorry. I don't know right off the spot.
Good afternoon, Chris Santinello, Associate Commissioner. I don't have that number right off the top of my head, but I can get that for you.
Okay, a follow-up. And I guess I was wondering how they've been affected by cuts in federal spending this year.
So cuts in federal funding to Head Start are going to impact New Hampshire in several different ways. The first thing is some kids are not going to get childcare, some of the lowest income kids in the state of New Hampshire. And part of what Head Start does, the childcare scholarship does not do, is that it will fund childcare or preschool experiences, getting children ready for public school, which is really important, for people who would not necessarily qualify for childcare scholarship. So for example, if you had a mom who is at home, low income, but had a disability, she may not be able to act because she doesn't work. She may not be able to access childcare scholarship, but she could access Head Start, and that would benefit the child and get them ready for school. There's been a lot of confusion on the federal and state level, and part of that is the departments on a regional level have been really shifted too, so it's hard for us to get information from our regional leads at this point. But the big impact I see on childcare writ large is that the people who are served by Head Start, who qualify for state scholarship, are all of a sudden going to start drawing down those dollars for state scholarship quickly. And they're going to be reimbursed at the highest possible rate, right? Because the income levels for Head Start are very, very low. So I suspect if Head Start does not exist anymore, we are probably looking at a wait list for childcare scholarship much sooner than what we ever would anticipate. I don't know if you agree with that.
Or
Dun, dun, dun.
to look at ways to avoid a child care wait list, right? Right now, we don't have a wait list for child care scholarship, but I think I don't know if it was in Mary Ann's report, but we've had a significant growth because we did change the income guidelines. So like Mary Ann said, the Head Start piece was never even on anybody's radar. So we would need to look at that. And there is some language in HB2 as passed by the House that would allow the governor to look to request other resources to avoid a child care wait list, because we all know that's critical for our economy.
Representative McDonald.
Thank you, Mr. Chairman. On the page looking ahead, you mentioned pursuing alternative revenue streams to fund childcare sustainability. Do you have anything specific in mind, or have you, are you considering anything specific? Or?
Yes. So this is something that Chris Santinello and I have spoken about, and the relationship between state and federal funding and childcare right now is based on the idea that childcare is a public good, that parents need to go to work, but it's run through DHHS for families who need support, correct? So it's like, my family can't afford childcare, so we're going to apply for childcare. We might get TANF funds too, but it's through the support, it's through the concept of supporting the family. we truly believe, the Child Care Advisory Council truly believes that the only way child care is ever going to truly prosper in New Hampshire is when part of that, the concept of childcare as an economic driver, moves over to probably DRED, moves over to resources and economic development, because childcare is economic development. So you can't have Amazon come here and say, we're dying to build a distribution center here without saying, okay, is there enough housing for people and is there enough childcare for people, right? So if there was a division that truly looked at how can we use childcare as part of our package, as part of our New Hampshire economic, the greatest place to do business package, that's not going to be DHHS's bailiwick. You know, they don't have the capacity for that. That's not what they do. But it is something that DRED does, or it's something the Department of Labor does. And that would be an important partnership that we don't have right now.
And I do think what Marianne said about partnerships is really important, right? Because we have certain pieces of the puzzle, and it gets difficult because as we pay for those children on child care scholarship, those families who do not qualify, those providers still need that income coming in. So how do you blend that and bring that together? So it's like this Venn diagram of so much overlap where different pieces, people have pieces of the puzzle.
And there's a benefit to bringing business to New Hampshire, right? We all know when Walmart opens up a new store, that means something to that community. That means jobs. That means people are getting benefits, blah, blah, blah. And childcare is a piece of that too. And I think that that's something that for a very long time has been ignored as we've focused on children and families. That's still going to be our most important work. But luckily with childcare, you get a twofer.
You had mentioned a few organizations that you are not currently connected with. Is that something that's going to change? You reaching out and making your case to them?
Yep. Yes, we're working really hard to build our relationships with the business community.
Good. Representative McDonald.
Thank you again, Mr. Chairman. I know, getting back to this revenue stream situation, I know labor, for example, gets a lot of revenue from different fines they impose when employers don't post notices and so forth. Greta, I'm less familiar with, are you envisioning perhaps certain fees would be dedicated to funding childcare? Would that be a possibility, or?
That would be wonderful if you're willing to offer that up. But yeah, so
Is that something you're thinking, perhaps?
no, it is something we're thinking. So I'm going to use as a perfect example of this. How much does it cost to have an LLC in New Hampshire? We have a bazillion LLCs in New Hampshire, and it costs less to get one in New Hampshire than it does any state around us. So how do we look at that? Can we look at the LLC fee and say, well, maybe that goes up, and maybe that nexus goes towards supporting the child care infrastructure? But that's the sort of thing that if we had a stronger relationship with economic development, we would be able to put forward as a concept of how those funds might support the infrastructure in child care. There are also, I know that Executive Councilor John Stephen mentioned that there's a grant that goes through economic development, federal grant that's towards workforce development. And how can we tap into that? How can we say we really need workforce development in New Hampshire and childcare? How can we tap into those funds and apply for those funds?
Has there any work been done in theory on, let's say, incentivizing Walmart to have a child care facility on its property offset by some reduction in its business taxes?
There has, but sadly what happens is there's no one to work there in that child care facility. So our biggest problem with child care in the state of New Hampshire is we have empty spaces because the wages are so low. So for example, I run a good sized nonprofit. At any given time, I might have enrolled 10% less of children than I could because I don't have enough staffing to maximize my spaces. So really what we would like to see first, before anyone gets in the business of buying the tiny toilets and dealing with regulations that they don't quite understand, because we are highly regulated, let's increase the staffing to increase the spaces statewide to really make sure that all of these empty classrooms are open. And that will truly, I mean, it's an incredible amount of empty spaces. Fiscal Policy Institute did a report on it recently, and I don't have it on me either, but it is a lot. It's thousands of spaces.
Representative Weber.
Thank you. It's hard to raise the hand while one's still typing when they're still speaking, but I appreciate it. And thank you for taking my question. Way back when you mentioned zoning regulations, and it was my understanding that at one point, not that long ago, by which I mean when I was serving in the legislature, which actually is since the late Stone Age now, I thought we had a statute that said that if it was a home-based childcare, it was allowable anywhere that you could have a home, as opposed to having to be in overlapping districts.
Yep. So that did pass. So right now we're looking at disseminating that information and ensuring that places like you have to get health inspections and fire inspections to open up a family childcare program. So to make sure that the smaller towns or places that may not be completely cognizant of that understand that these things all have to go together. So a lot of this moving forward with our zoning work will be education and really documenting and researching how successful it's been.
Thank you.
Representative Woods.
Thank you, Mr. Chair. Along that same line, you sort of alluded to this process of the regulation and needing this and that. Is the overall licensing process at this juncture a bottleneck, or is that sufficiently streamlined, or should be further streamlined to enhance this overall process?
I think our partners at Child Care Licensing are terrific. They really do a great job. And they have done a very, very strong pivot to understand the challenges that the child care field is struggling with right now.
Well, that's good to hear. My daughter works there.
Oh, yay. Oh, excellent.
Good answer, Mary.
I know. I was going to say, they're terrible. No, I was just going to. And that's my entire report.
Thank you.
Thank you very much.
Anything else, Associate Commissioner?
No, I'm all set. Thank
Good.
you very
Thank
much.
you so
welcome.
much.
Next up, 2023 New Hampshire Suicide Prevention Report. Amy Cook, Chair of the New Hampshire Suicide Prevention Council. And Jenny O'Higgins. How long has it been, Ms. O'Higgins?
1 day.
1 day, yes. You know,
sorry,
that delay was
I
not
need
so
to-
bad. The clerk
I need
needs one
to-
for the file.
Thank you. Oh, okay. I didn't
Now the
need
clerk
that
has
many.
two for
I
the
just
file.
needed
Yeah.
one more for the file.
Got it.
Good afternoon, everyone. Thank you for asking us here today. My name's Amy Cook. I am the chair of the New Hampshire Suicide Prevention Council, and we're here today to go over our annual report with you, just share some highlights. Jenny just passed out the infographic that gives some of those statistics for you. And just before she starts getting into the interesting part, the statistics, I just wanted to let everyone know the basic overview of the Suicide Prevention Council. It is legislatively mandated. It oversees implementation of our New Hampshire Suicide Prevention Plan, evaluates implementation, recommends any program changes, initiatives, funding opportunities, new priorities, and we also, are viewed as a proponent for suicide prevention in New Hampshire. We have 24 statutory members on the council that are outlined in the legislation. The representatives are from state government, associations like the Community Behavioral Health Association, New Hampshire Hospital Association, and many of our nonprofit partners as well. Leadership consists of 3 elected positions and 1 appointed by the chair, which is the treasurer. The elected ones are chair, vice chair, and clerk. And then we have public open meetings. We meet every other month, and those are often attended by upwards of anywhere from 20 to sometimes 40 people or more. So we have a really active group. Even if they're not statutory members, they're always giving input into the work that we do. We have several committees: communications, survivors of suicide loss, public policy, data, military and veterans, first responders. We just started a youth committee, and then we have a conference planning group as well. So we're a really active council. We do a lot of work throughout the state, and I think the partnerships that we make and the collaborations that we pull together are probably one of the highlights that you don't necessarily see when you're looking at the data. So now I'm going to turn it over to Jenny for the interesting things.
Yeah, we'll get into the data a little bit with you. So I'm Jenny O'Higgins. I'm a senior policy analyst and legislative liaison at DHHS.
I'm sorry. You spoke very fast.
Okay.
So, and I am a lousy typist. So could I ask you just to repeat the groups that you were collaborating with slowly so I can get them down?
Yes. So we have 24 statutory members.
That I got. It was just the groups. You said veterans, you said.
Oh, the committees. Yes. Yep.
So
we have
are these, if I may, Mr. Chairman, just for clarification, are these committees composed of the statutory members, or are they committees that are statutory members and other people?
the last one there, so both.
Okay.
Yep, there's statutory members on each committee, and then it's also a bunch of other people who help out as well.
May I suggest that next time, all this is in the report?
Yes.
Thank you.
We have a communications committee, survivors of suicide loss, public policy, data, military and veterans, first responders, a youth committee, and a conference planning work group for our annual conference.
Thank you.
You're welcome.
So the membership of the Suicide Prevention Council and the committees also are in the annual report. So we did provide the annual report electronically, just because it's, I think, over 90 pages. We were giving you a high-level overview of the data today. But I will make sure that you also have all of that information in writing, in email, so that you can refer back to that at any time.
That's good.
So in looking at the 2023 annual report, we look back at fatality data. And so we do have there's a lag in how that is reported. And so we come to you today to talk through the 2023 annual report, last year having been in front of you with 2022 numbers. So in 2023 was the 15th anniversary of the Suicide Prevention Council, and there were also a few changes to the council in that we had hired in New Hampshire a statewide suicide prevention coordinator to really be able to look across all of these multi-sector work in state agencies and with nonprofits, and be able to look at how prevention is being done and how those collaborations work. It was also one of the first times that the Suicide Prevention Council had some state funding. So it was $100,000 a year, but made a huge difference in the amount of training to be able to be available throughout the state to get more people trained in suicide prevention. And so we're going to talk about some of this overarching data at a high level. And suicide is a public health issue and is very preventable, which is why we are always here to talk about prevention. However, when we're not in the work day to day and working on the interventions and the preventions, and then we just hear the numbers, they can be alarming. And so I just want to start out with a level set to remind people that in general, suicide is rare, and that suicidal ideation or having thoughts of suicide is treatable, and that most people who attempt suicide do not later go on to die by suicide. So just a reminder that effective programs exist and that recovery and resilience are possible. That is my initial level set to every data conversation. So in the 2023 report, you'll find a few things that are new this year. We were here last year to go over the report with you, and this year we were able to get some updated data from our vital records and violent death statistics that allow us to break out demographics and self-harm hospitalizations a little bit further. They give us some greater detail around the circumstances surrounding fatalities in New Hampshire that help us understand when and how to intervene. The other pieces that you'll see that are a little bit new within the larger report are some data around 988 and rapid response. These are our crisis access lifelines, and the amount of folks that are accessing those resources really shows how much people in New Hampshire are starting to seek help, which is critical prevention. So we're glad to see awareness and people reaching out. That means that stigma is reducing and that people are help seeking, which is critical. And then the other piece that's new is that you'll see some additional highlights of activities that are happening across the state. And some of that, more of that is happening with our position of the suicide prevention coordinator and with the funding that the SPC has. So in New Hampshire in 2022, we had 248 deaths by suicide. You will see in your infographics that in New Hampshire, our crude suicide death rates have been above the national average. This has been true for more than a decade. And suicide has been a leading cause of death nationally and in New Hampshire. In our youth age group, it has been the second leading cause of death for a number of years as well. So you'll see why we are so concerned about doing, great suicide prevention in New Hampshire and making sure that we're utilizing data to make informed decisions about what populations are at the highest risk and how do we target intervention and prevention to have the biggest impact and help people get the help that they need. We have seen a slight decrease over 2019, 2020, 2021, and that is all hopeful. But in New Hampshire, we're such a small state that the numbers are small, and so it's not really statistically significant. And so we just try to keep our foot on the pedal in terms of the prevention that we're doing and making sure that although we're seeing those, that doesn't mean, hey, we just know we're moving in the right direction, right? That means we keep watching and we make sure we see that statistical significant change over time. So you'll see also in your infographic the New England map, and that's showing you around the average rates. And as I said, New Hampshire has been above national average. You'll also see that being above the national average is not limited to New Hampshire. All of the northern New England states are above that national average, and our southern New England states are below that national average. So looking at the why and partnering with those states that have lower rates to understand what they are doing that's working is really critical to our work as well. You'll see in your, oh yes.
On that, is there a factor that society can have a positive impact, whereas if you live in a rural state and you're alone, I'm not quite sure where I'm going with that thought, but is the rural nature of the above the line and the urban nature of the below the line a factor?
Absolutely.
Okay, thank you.
So many of the factors are, isolation, access to healthcare, having a increased stigma when we have sort of a pull yourself up by the bootstraps mentality that doesn't allow people to access help seeking as easily. So we're trying to work on that. As I said, seeing our people accessing our 988 and rapid response lines is a good sign for New Hampshire that people are help seeking. But those are all factors, and access to lethal means, in particular firearms, is a particular risk factor for suicide, and we see that in more rural states in general.
Sure, thank you.
Sure.
Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. I guess the statistic that really banged into my eyeball really hard was the fact that our neighbor to the south has less than half. I mean, it wasn't that we were just a little bit more. They're less than half. And I'm wondering what your take on that is, but my specific question would be, is that because, for example, of the amount of resources that we do or don't direct towards the community mental health centers and the accessibility there, and also workforce issues?
Yes, so suicide is very complex. It's a number of factors, and we have to have a multifaceted approach to how we do prevention. I think you, Representative Weber and Representative Pearson, have both already identified some of the issues that we're looking at already, right, including economics and workforce and housing and as well as the access to care. So the additional resources, the having behavioral health, close by matters. So the rural nature of our state and where we can and can't easily access care. We also see that with our county data. So when we look at our suicide rates by county, we do see higher rates in our more rural parts of the state. So this continues to track whether we're looking at the nation, New England, or right inside New Hampshire, and that's one of the reasons, again, that having a crisis line that's just accessible always everywhere for 24/7, it's not the be all end all. We need the full system of care to refer people after crisis, but it's a starting point where it's more accessible regardless of where you live. And so those are some of the ways that the Suicide Prevention Council looks at, we know this to be true. What can we do about it?
Follow up, Representative Weber.
And I was wondering if you could get us the county numbers.
Yes, and that is in the 90-page report that we sent you electronically too, but I can send you.
But perhaps a one-page would be very kind.
Absolutely.
Thank you.
Absolutely. Okay. Oh, sorry.
Representative Dry.
Thank you, Mr. Chairman. Thank you for taking my question. So I've been in rural EMS for 45 years. And when I closed my eyes and tried to figure out what was going to be in this report, really, firearms, men, I've got it all. We have access to 988, and it's well broadcast in our county, Sullivan County. But we have 2 mobile health vans, and what they tell us as EMS is they might be available if we have staff. So it's not something that we can depend on to be available. And as you know, there's no timetable for when people have emergencies. And so that's been a real hindering point for us. Is there any hope on the horizon?
Thank you so much for that question. It's so important. I think in New Hampshire, just in the last 5 or 6 years, we've started completely transforming our behavioral health crisis response. And so with that, we have, our rapid response access point, our 988 call line, call, text, chat. We have mobile crisis, and now we're piloting these 2 crisis stabilization centers. Those are sort of the 3 pillars of behavioral health crisis care that are best practice, and New Hampshire's getting there. But when something's that new, it does take time to get up to the quality that we wish that it would be. And in particular, I think you're naming a workforce challenge, and we know there's workforce challenges across the board and in behavioral health. And so I think we get creative. Is what I would say, is that we continue talking about how do we do it? How do we partner with EMS and, community paramedicine? How do we partner with others on the ground to be able to respond? There are states who utilize an EMS co-response model. There are states who utilize wilderness first responders, emergency rescue, especially in these rural areas, because we know that even just having someone to sit with during a moment of crisis with a little bit of training to have the right kind of courage and language to show up can help keep someone alive. Not dissimilar from the fact that we train community members in CPR, right? And we're not making them a medical professional, but we might be able to sustain a life until we can get a medical professional. So those are some of the creative ways we're thinking about it. I don't have a solution for you today, but I do feel like New Hampshire has made incredible strides over time and in a pretty short period of time. Thank you. So continuing along your infographic, you'll see, some of the rates around the percentage of adults that have had thoughts of suicide. This is from the Behavioral Health Risk Factor Surveillance System. And we see that untreated mental illness is a significant risk factor for all ages. So thinking again about all of us just being able to have the message that help is available, to know the resources and to refer people to them is a critical step in prevention. And New Hampshire continuing to invest in mental health and in the awareness of that over time. And then we also look a little bit at youth statistics throughout this infographic, again, just high level. And our youth risk behavior survey data shows us the similar data from the behavioral health risk factor surveillance system that we have for adults. So it shows us thoughts of suicide and those who have made an attempt on suicide. And also you'll see the question around students who are feeling sad and hopeless. That number has been pretty striking, pretty high over time in the 30 to 45% range there for our number of high school students reporting feeling sad and hopeless. You will see that we put in this year's infographic and report, we put 2019, 2021, and 2023. The survey is given every other year. And the reason we didn't just put 2023 is also to show that we had this spike in throughout the pandemic where we have heard a lot of kids feeling more feelings of sad and hopelessness. We saw this rise in that statistic, and that now we feel like it's potentially moving in the right direction with seeing a slight decrease. But even though we're reporting out a decrease in that question, we're not even back to those 2019 numbers. So again, just something we have to keep our eye on, and we have to keep connecting with youth to understand why.
I have two counselors on my staff, my day job, and they often say to me, there is a popular definition of a word and there's a clinical definition. And so when you say sad and hopeless, how is that defined?
The way the question is asked is based off of the clinical definition because it says for a period of 2 or more weeks. And in the last 12 months or something is how it's asked. If I forget the exact phrasing, but it's asked in that way for us to get a sense of this. But this is self-reported. So we're not saying this is a clinical assessment and we're saying that these are kids who have depression, but we're saying kids are self-reporting that they've felt sad or hopeless for a period of time.
Period of time.
Yeah.
Yes. Okay. Thank you.
Yes. So, that gives you a little bit of the picture of how kids are doing in New Hampshire. One of the other things that's going on with that data is that there's the Getting to Why program. And so the kids themselves, the students, are using the data to then ask, well, why are our peers reporting this? And then that digs in a little bit further to say, what do we need in those prevention intervention areas? So, there is so many different things happening, so many highlights of this work across time. We also, the Suicide Prevention Council, has a new strategic plan that covers 2025 through 2029. And we're really doing the work in New Hampshire, making investments and making a difference over time. The focus in the new prevention plan is around using the data, making sure the data is as clear as it can be, and how do we help that to use the data to identify the most at-risk populations, geographic areas, ages, things like that, and dig in. So for an example, we find directly in the data that there's for young males, that there's a specific period of early to middle adolescence and late to adulthood, for males in particular, that are at where the risk really jumps. And that allows us to target prevention programming to a potentially really at-risk group. So that's just an example of how we utilize data directly to then inform prevention.
Are there peer-to-peer programs in schools where a few well-trained youngsters can run an after-school thing for another student who's feeling clinically sad?
Yes, I think there are many examples of programs that are youth-led throughout New Hampshire, not necessarily everywhere though. So I would say we have pockets of excellence in New Hampshire where we can see prevention happening really well. And now we need to start thinking about where we know it's working well and we can see those outcomes. How do we spread that throughout the state? So part of even having the council that's statewide and the suicide prevention coordinator who's looking statewide is to look at where are we doing it, where it's working, and how do we make sure that that's actually available to everyone.
So this is an intentional, ongoing work of the council to get this in more places.
Yes.
Thank you. Representative Dry.
Thank you. Mr. Chairman, thank you for taking my question. So I know you're called about suicide prevention, but the people left behind, I have a 988 number to give out to everybody who's in mental health crisis things, but I really don't have the equivalent on the other side for the family or the friends to do. Is there something equivalent to that?
Thank you to every single question that we've gotten today because they're so thoughtful and they're so important. And I appreciate it. It's also directing us to give you better information and to be by giving us the opportunity to answer these. So it's another excellent question. The council has a survivors of suicide loss subcommittee that meets regularly and then partners throughout our coalition, such as NAMI New Hampshire, have a lot of resources for survivors as well. And postvention, which is how we respond after a death by suicide, is prevention. So we actually know that all those who have a suicide loss are at increased risk for suicide themselves, and our postvention response is critical. Some of the pieces that are critical around that too are media and coverage and how we talk about suicide, not sharing location and method, not sensationalizing, reduces the risk of contagion and clusters. So there are these really critical steps. New Hampshire just this fall and winter held multi-stakeholder postvention training, 2 full days where we came together to look at what's the state's responsibility and the local responsibility and how do we really coordinate protocols around communication so that we can do our best response after a death by suicide.
If I had someone come to me and say, somebody in my immediate family just committed suicide, is there a support group? Who would I call to find that out?
I would direct you to the NAMI New Hampshire website
NAMI?
where there's
Okay, yep,
specifically
got it, sure.
survivor,
Good friends with NAMI.
resources and support groups. And that would be the very first step.
Good.
Also, New Hampshire, after someone dies by suicide, does send home a resource packet to the next of kin, specifically with postvention information that comes from the Office of the Chief Medical Examiner. And so that's a specific prevention strategy that New Hampshire has implemented. So I just want to leave you all with resources so that you can share them. So I will also pass out some, 988 wallet cards that I didn't bring up with me the first time. And then I will make sure to follow up an email with the information that you all have requested today and make sure that you have the full report as well as the membership and county data.
Representative Woods.
Thank you. I just was thinking along here. Thank you for allowing me to ask a delayed question. When we think about prevention, we think about this in many, many different dimensions. When parents are confronted with a child who is thinking about using drugs,
there's the microphone a bit more.
With parents who are faced with a child who is working with, thinking about toying with drugs, they're given some counseling. Is there a similar program for parents that, is my child having some difficulty? When do I begin thinking about this particular issue? When I see it in the paper, it seemed like it just came out of the blue. Are there programs for parents to help them be aware of not just the fact that they're being aware of your child could be taking drugs, but is there similar for this? Is there a program for that?
Yes. So every question, again, has been so good and thoughtful. Thank you again for allowing us to share additional information on that. So I think some of the things that we can do is that, remember that suicide prevention is everybody's business, that it's a community issue, how we talked about CPR earlier. There are ways that you can learn how to recognize the signs and the risk for suicide in yourself and in others. You can, utilize the Connect program through NAMI New Hampshire. Question, Persuade, and Refer is another thing that you can do either online or in person. Youth mental health first aid and mental health first aid. All of these are also programs that are often offered free of cost in New Hampshire. So there's some really excellent ways to start to understand early warning signs and symptoms and be able to then help connect to care. And other pieces that we can do, is just support policies and legislation that promote mental health and suicide. You've heard a lot of me talk a lot today about 988 and rapid response, our Mission Zero work. It's all connected in our children's system of care. And so supporting that work and taking these trainings ourselves and passing it along to all of your constituents, friends, family members, letting them know that there are these free, resources where we all can learn the warning signs of suicide and we can all have some of that courage and language to know how to respond. those are critical steps.
And I just want to add to that, NAMI New Hampshire has an info and referral line. And so sometimes parents will just call up and say, I'm worried. You know, I'm not really sure what's going on. Something's wrong. I'm worried. I don't know what to do. And so we have a lot of support programs. I work full time at NAMI New Hampshire. So we have a lot of support programs to connect parents, educate them about what it's like when your son, daughter, your child has a mental health issue that you've identified. And I would also add to that, even 988 itself, a lot of people don't realize that you, as the worried family, friend, teacher, can call and say, I'm not the one in crisis. I have a friend, I have a child who I something's wrong, I don't know what to do. And the people on the end of that line will gladly walk you through some resources, ways to talk to that person, coach them into care, just kind of give some resources. Thank you.
And you're going to be walking up some cards to us,
Yes.
Counselor. Thank you.
Thank you.
And we will just finish. And I'll call up the next people. But since you're already up, you can stay.
Good afternoon.
Just don't start.
Oh, then I won't.
We're going to wait for this. Come on up.
What are we waiting for?
Well, we were waiting for something, and we're almost there, I think.
Does the person we're waiting for know we're waiting for them?
Well, I thought so, but
Because it doesn't appear so.
yeah. All right, the chair recognizes, sitting before us, Prescription Drug Monitoring Program Annual Report, Adam Birch, Administrator, and guest.
Yes, I'll introduce myself. I'm Whitney Hammond. I'm the Interim Deputy Director for Public Health.
Okay, good.
Good afternoon. Realizing that I am the last thing that sits between you and more adequate air conditioning, I will be direct and to the point.
I like this guy already.
If you would like to flip to page 2 of the packet that I distributed earlier, the top
Which
slide
looks
number 3.
Like what? Looks.
It should be in color, and it should have my card attached to the top.
This one.
I don't know if I have that. I don't think I have that one. Yeah, we'll take it from there because I want to give that to. Oh, this is an extra. Okay, good. Thank you. Anybody
Excellent.
else not? We all good? Go.
If you switch to page 2, the top slide, you'll see a brief highlights. I just want to point out a couple of things there. The registrant count, the people who are the healthcare professionals who are required to register with the prescription drug monitoring program, they have been relatively flat in total numbers for quite some time. We have a few people who retire each year, some new people who graduate. We have some who move out of state, some who move into state. And that has been flat for quite some time, which is why the next bullet directly below that, the utilization by those healthcare professionals is up 18% this year from last year. That is the result of about a 2-year quality of life improvement effort that we've been working with our vendor on and with the healthcare professionals that use our system to put in place. We've made it much easier for them to access our system directly from their electronic health record, using the patient information that they have for the patient that is in front of them to connect quickly and get information from our system about that patient quickly. That way we're matching the records in as close to real time as we possibly can. The graph at the bottom and the next two on the next page those three graphs, I want to point out that they need to be taken in context with each other. If you look at just one, you'll see that stimulants are on the rise. They have been on the rise year over year for a while. What I would like to point out is that the total number of filled prescriptions for stimulants, the total number of days supply for stimulant prescriptions, when you count them against the total number of people receiving those prescriptions, that's stayed relatively flat for a long time. What we're seeing is more people being prescribed stimulant medications, and there are a couple of things that feed into that. What we're not seeing is a dramatic increase in the amount of prescriptions any one individual is seeing. So this is an overall volume increase as opposed to signs of high-risk prescribing or something like that. I want to touch very briefly on opioids. So if you switch to page 5, the bottom slide, slide number 10, you'll see that since the start of our data in 2017 through now, opioid prescriptions have dropped, but they're starting to plateau out, and that is what we would expect to see. We've seen a decrease in the high-risk prescribing of opioids, the ones that lead to the greatest risk of substance use disorder, addiction, abuse. And we've also seen a decrease in the number of bad faith actors, the people who are purposely abusing their prescribing privileges or purposefully trying to obscure that they get prescriptions from multiple sources. We would expect it to stay relatively flat for the near future. There's going to be an equilibrium where patients are getting the medications that they need, nobody is taking advantage of the system, and the highest risk prescribing is largely gone. So it should stay relatively flat for years on end, just as changes in standards of care shift over time. Which means that I want to move on to the topic that our advisory council is most interested in. I would expect you guys are as well, the topic of stimulants. If you switch to page 9, the bottom slide, slide number 18, you'll see that from last year to this year, the largest growth in stimulant prescriptions is for adults 30 and over. And there are a couple of reasons that we think are behind that. One is that the diagnostic criteria for attention deficit hyperactivity disorder, ADHD, which is what stimulants are often prescribed for, was broadened. And the people who are in the 30 and over category, they would not have been diagnosed as children, but now under the wider diagnostic criteria, they can be diagnosed as adults based off of the different symptom presentations. So it's very similar to when the diagnostic criteria for autism spectrum was widened, the number of people diagnosed with autism spectrum increased. And we're seeing a very similar thing with ADHD diagnoses. The criteria has widened, and so the number of people who now meet that criteria is bigger than it once was.
I forget what national media had this, but apparently, according to them, when numbers of people are diagnosed with something, a number of other people now think they've got it. And so there is a self-diagnosis, at least, that is skewed.
While there can be more people seeking a diagnosis, presenting to a healthcare professional, asking for an evaluation, we'll see a follow-up just shortly afterwards that says that our healthcare professionals are exercising all the due diligence we would anticipate of healthcare professionals acting in good faith. So if you move to, this will touch partially on it. If you move to the next page, page 10, the top slide. This is, what you can see is that there is a difference in the prescribing rates between men and women based on the age bracket. And the largest growth that we have seen is in women aged 30 and over. This was brought up at the National Association of State-Controlled Substance Authority Conference, where all of my counterparts from all the different states come together, talk about potential risks, what could we see problems with in the future. And what they brought up was that there was targeted advertising that was going out to certain demographics that was focused on improving focus and concentration and productivity. This will, by its very nature, prompt some people who may not have gone to seek evaluation before to go seek evaluation. And at the exact same time, we had an expansion in access to telehealth services, meaning that people who may have had to drive an unusual distance to see a healthcare professional now had the ability to have an appointment from the comfort of their own home, meaning we have a higher usage of patient appointments as well.
Representative Weber.
Thank you, Mr. Chair. I know we have a bill working its way through the legislature to expand telehealth services even more. So am I right in thinking that we might see a similar bump if that goes through? Because it lowers the need for establishing an in-person relationship before. And one of the things the committee thought when they looked at it was having a robust prescription drug management program will give an early warning if there is high-risk prescribing going on or misuse of the prescribed dosages.
Thank you for that question. What I would expect whenever you see an increase in the number of people who can access healthcare professionals is you're going to see an increase in prescriptions. The only prescriptions that our program tracks are the ones that are Schedule 2 through 4, those that are at risk for abuse. If we had an expansion of telehealth services, I would fully expect to see more people prescribed blood pressure medication, more people prescribed diabetes medication, more people prescribed a wide variety, but we're only going to see the ones that are tracked in our system. And if we were to see signs of high risk use, yes, we have a robust system that is very accurate, which I will touch on towards the back of our report, where we would see the number of prescriptions or the number of days supply per person shift. Because if the total number of people increase, that doesn't necessarily indicate that those new people who are being prescribed are going to start abusing the medication that they've been prescribed. They might be following it exactly as prescribed by their healthcare professional. And if we don't see a shift in the rates per person, then we can say that our clinicians largely are still doing their due diligence, ensuring that the quality of care is there and that the people who need medication are getting it and the people who may not need it are not getting it. Which actually brings me to exactly why this is important if you switch to page 12. Seeing the trends that we saw in our data had us concerned. It had our advisory council concerned. And what we did was we partnered with Medicaid. Our system only tracks the controlled medications for ADHD. There are non-controlled medications for ADHD as well that have, as far as the DEA has evaluated, no risk for abuse. And during the same timeline, we're seeing an increase in both that are very similar to one another. The non-controlled ADHD medications are much newer, means that less physicians are likely to be familiar with them, less people have most likely heard of them before, and unfortunately we do have a world where ask your doctor if X is right for you is still a common form of medication advertising, which prompts some clinicians to follow the request of the patient as opposed to looking at the entire collection of options. And then we also have differences in what one insurance will cover versus another insurance. So we are still, with new medications coming that have only been around for a few years, it's not surprising to me that they're not the majority of ADHD medications, but we're not seeing a decrease in those prescriptions. We're seeing an increase in the non-controlled, the low-risk prescriptions as well, which tells me that the clinicians in our state are taking advantage of all the tools available to them and attempting to match the treatment with the patient, which is what we would want. And the last part that I will point out is if you switch to page 16 and 17, the top slide on page 16, The data that is in our system that our clinicians around the state rely on has a 99.8% accuracy rating. And this is because of the tireless effort of our compliance auditor, Leslie Pond. She makes sure that the data coming into our system is accurate, matches what was dispensed, so that that way the healthcare professionals who are querying their patient's history can trust that the data in our system is as real time as possible, as accurate as possible, so that they can make the best informed decision as they can. And if we go finally down to the final page 17 that I'd like to highlight today, what you can see is that there has been a dramatic increase in the number of Gateway queries. Gateway is our electronic health record integration. It is what allows the clinician to be able to access our system without having to go to a web portal. It makes it much faster, much easier, and it matches it based off of the patient's name and date of birth in the electronic health record to make sure that the right person is being queried at the right time. And that has seen a 68% rise just since last year. Part of that is because more facilities are putting it into action, they're implementing it. And then part of it is we discovered through talks with the healthcare professionals that access our system that our neighboring states weren't automatically able to do that, even though we have interstate data sharing agreements with them, meaning that if I was driving in Massachusetts, I got into a car accident and I'm unconscious in an ER, that ER physician may or may not have been able to look my name up in the PDMP quickly and efficiently. Now they can, and as a result, we see much more consistent usage. The very last thing that I would like to point out is the bottom slide on page 18. Now that we have a system where 99% of the prescribers who are supposed to have access to our system at any given moment have access to our system, there's always going to be a bit of a delay between when somebody is initially licensed and when they register. And now that we can say that the data in our system is very accurate and can be delivered timely, what we want to do is start looking beyond the mandatory requirements for accessing our system and encouraging the best clinical practice usage. If a physician was about to write a prescription for an opiate, they're required to query my name in the system to see if I have a record. That way they know whether or not I already have one or whether I have a medication that will interfere with it unexpectedly. That does not apply to something as simple as an antibiotic. And you'll see that we have listed several medications. These are non-controlled medications that interact with buprenorphine. And buprenorphine is the main medication used to treat substance use disorder for opiate dependency. And the last thing I think any of the clinicians in our state would want is to prescribe a regular antibiotic that then disrupts the substance use disorder treatment of the patient, because that person is very unlikely to be prescribing both. Getting our clinicians to query the system through their electronic health record, even when it's not a controlled prescription that they're writing, ensures that these types of unwanted medication interactions are as minimal as possible, and the patient is likely to still need that antibiotic. That clinician can then tell them, this may or may not interact with another medication that you're on. If anything seems wrong, if anything seems off, call that prescriber right away, let them know. That way we can ensure people are able to maintain the quality of care that we want everyone to receive. And that is all that I have.
Any questions for Mr. Birch? I find air conditioning to be overrated, so I'm ready to stay a little while if you have some questions, folks. Representative Woods.
Thank you, Mr. Chair. Not a question, but a compliment. I retired, but in the early 80s, when I first came to New Hampshire, the scene when I was on call for orthopedics for Concord Hospital was vastly different. And this has all contributed both to my, well, I should say physicians in general, ability to treat patients properly and in a timely fashion. So, and it is a little bit of an onerous overlay, but it's all for the good. But thank you.
Thank you.
Representative McDonald.
Thank you, Mr. Chairman. On page 11, the bottom slide, I noticed that Merrimack and Stratford counties are the darkest red, and I was just wondering what you attribute that to.
So,
Age-adjusted rate of New Hampshire residents with a stimulant prescription.
yep. So the reason why we do age-adjusted rates, and we did it also for opiates as well, is because there are some age categories where you would expect a higher utilization rate than others. It's not that surprising to see higher opioid utilization in our older population because they're more likely to have chronic pain problems, chronic arthritis, things like that. When it comes to the higher rate of stimulant usage in the southeastern corner of our state, that's where our highest population density is. That's where the highest discussion, the highest access to prescribers is going to be. And it is also where people are going to talk with one another about getting a recent diagnosis for ADHD. Right? News spreads faster. Population density. The reason why it lights up darker is because we're seeing a higher rate in older populations than you would have historically expected. And that comes mostly from the rise in the 30 and over category. The other factor that we have to consider is that stimulants are now being used to treat dementia. There is some emerging evidence that they can help reduce dementia symptoms and slow the cognitive decline. We don't have the ability to filter out to that level of specificity in our system, so we look at the county as a whole and the entire utilization as a whole, which is why I caution reading in too aggressively. It's actually the reason why we looked at the controlled stimulant and non-controlled ADHD medication in parallel, because if we only see just a narrow blip of information, we can be drawn into maybe making guesses that aren't going to be accurate over time.
Follow up.
Thank you. So at least on the surface, the initial impression would be that Merrimack and Stratford, they tend to have the older populations. Is that why they're the darker red? Or
No, what I'm saying is that in those, when you adjust for age, the increased use in older populations is going to show up more in some areas. It's a matter of small numbers and percentages, as opposed to being sort of, I don't want anyone to think that I'm saying that everyone over the age of 50 in one county has a prescription for ADHD medication. It's just that certain increases are going to look much bigger with when you start to age adjust because the populations themselves are smaller.
thank you.
Representative Woods.
Thank you, Mr. Chair. With the robustness of the database that you have, has there been any blowback about privacy issues?
Thank you very much for that question. We have a policy, standing policy. Anytime a person requests a copy of their own record from our system, we automatically send them the entire audit trail that comes with it that shows every person that's ever looked at their records. I myself take patient privacy extremely seriously. I was in practice for years before I joined the state. I was a HIPAA compliance officer for 2 healthcare facilities, and we have every reasonable protection in place we possibly can. The only way somebody could access a patient record without having the legal ability to do it is if they have stolen the credentials of somebody who has. And we have systems in place to catch when that occurs.
Okay. Thank you.
Thank
you
you
so much. And 6 minutes of non-air conditioning was worth it. Thank you. And I have a stash of 988 emergency cards here that were just dropped off. And if any of you folks need them, I'll take a packet for our medical center, and they're right here. Anything, Maestro? With that, I adjourn the meeting of Health and Human Services Oversight Committee for Friday, May 16th, and I will keep in touch with you regarding should we meet in June. Thank you.